Hello, everyone, and welcome back to the Shoulders Up podcast, where we break down complex headaches and dizziness. So, today we're not going to talk about anything too clinical, but instead, we're going to talk about another subject, and that is advocacy. So, some of you may have already seen from my social media that I was in DC last week. And I was there as an advocate, advocating for better headache representation and legislation that would greatly impact migraine patients and headache patients. So it was actually my first time in DC, and I actually thought it was an absolutely amazing way to get introduced to DC. I was meeting with lawmakers, staffers. I was on Capitol Hill. I was in these congressional offices, Senate offices, and going in with the mission of hoping to get them to sign on certain legislation that we know would be really beneficial for the headache community. And of course, that impacts me directly, being a chronic headache patient, for those of you who don't know. And I'm an open book. I pretty much tell this to everyone, so most of you probably should know. But for anyone who doesn't know, that I am a chronic headache patient. I've had a headache for probably the past 7 years. It's a really long story, and it's actually quite a atypical and complex presentation, but I digress. So going back to this advocacy work, so who did I go with? And I went with, there's a group called the Alliance for Headache Disorders Advocacy Group, and it's a big group. So I would say it's like an umbrella organization, and it's definitely the leading voice for headache policy, and it's made up of various member organizations that are already quite big in their own right. So we're looking at Facial Pain Association, Coalition for Headache and Migraine Patients, Chronic Migraine Awareness, American Migraine Foundation, American Headache Society, National Headache Foundation, US Pain Foundation, and more. So lots of groups coming together, and this event happens every year, Headache on the Hill, where a bunch of advocates go to DC to essentially advocate for better legislation. And it's actually a biannual event, with one event being in person and the other event being virtual. So it's really exciting to be a part of. As someone who works with headaches and dizziness, of course, I love, treating them using, in my case, conservative measures, conservative care. But on the other end of things, yes, I do think it's part of my responsibility to go forth and push for better headache research, because the fact of the matter is, I feel very, very confident that if the right resources were allocated towards helping our headache patients, I think things could change very fast, and I think many headache patients would have a much better quality of life. So moving on, why do we need better headache policy and better legislation in the country? And we need this because the headache community is severely, severely underserved, and they don't get anywhere near the amount of representation that they should have. So first thing we have to think about is, well, how many people will this impact? How many people are living with headache or migraine? And the answer is that's currently at about 40 million Americans. 40 million Americans are currently living with headache or migraine disorder. And so that's about 1 in 6 adults that have reported migraine or severe headache in the past 3 months. Going beyond that, migraine is actually one of the leading causes of disability in the world. So in the world, migraine is the second leading cause of disability, just behind low back pain. And for women under 50 in the United States is actually the leading cause of disability. And the important thing to note is that migraine often impacts people at their most productive years, right? So people in their 20s or 30s, or when they're in school. So the economic cost of migraine is also huge. So we're looking at maybe 80 million a year being spent lost work time, as well as healthcare spending. And I think something that's really important to note is that also pediatric migraine is a pretty large proportion of the pediatric population. Many people do not realize that pediatric headache is a field in and of itself. And, a national study estimated that about 17% of U.S. children experience frequent or severe headaches in the past year. So already we're starting to see that there are a lot of people who have this disorder, and we're seeing that there's a large socioeconomic cost. And going beyond that, there are actually only, in terms of physicians, there are only 900 certified headache medicine specialists in the country for 40 million Americans. So if you break that down, that's about one headache specialist per 44,000 patients in the country. And I don't know any doctor who can see 44,000 patients in a year, but this is really what we're looking at. There really is a lack of care for a lot of people. especially headache patients who are in rural areas, because most of these headache centers, of course, are concentrated in urban areas. So not only do we lack the proper providers to meet this demand, we're also missing is adequate research. So as we kind of already discussed, a huge proportion of the United States is dealing with severely disabling migraine or headache disorder. But the spending by the National Institute of Health, the spending for migraine headache research remains very low relative to the disease burden, and headache disorders receive just 0.2% of NIH funding, even though we know that migraine or headache represents a very large proportion of the population. And all of this together really produces worse patient outcomes for migraine and headache patients, because what we do know about migraine and headache is that if it's not addressed properly, patients do become more sensitive over time, and the migraine disorder can certainly become worse. And the way I like to explain this is that typically we think of a migraine attack, someone has the attack, and then over the next few days it resolves, and then they go back to quote unquote normal. And this is true to, I would say, a large degree actually. But at the same time, when you think about it, every time a migraine happens, it's like your brain is being hit with a truck. Your brain's like just getting rammed by this train. And then when the train or the truck goes away, of course you feel better, but that doesn't mean that it didn't cause some damage, maybe some cracks that we don't see. And over time, if that keeps happening and the attacks are not controlled, then what we're going to end up with is a more sensitive brain and probably most likely a more disabling disorder. So generally speaking, early intervention and diagnosis definitely leads to improved outcomes and reduced disability. And people often develop these issues in childhood and adolescence, in their 20s and 30s. It's really impacting the most productive years of people that are dealing with this. So like I mentioned a bit earlier, so one specialist per 44,000 patients. And when I was in DC, our group was communicating with the lawmakers in California and Oregon, and someone on my team was a pediatric headache specialist in Oregon. And in Oregon, they only have 9 headache specialists. So over there, it actually counts for 1 headache specialist per 77,000 patients. And for her, she was the only pediatric headache specialist in the whole state of Oregon. So let's go back to talk a little bit about more spending. So how much does the NIH spend per person for certain disorders? So we'll start with probably the biggest, Alzheimer's and dementia. The NIH spends about $558 per person. Parkinson's disease, $269. Multiple sclerosis, $181. Epilepsy, $21. And then headache, $1.55. $1.55. And quite frankly, that's just not enough. So NIH spending is roughly 46 times higher in epilepsy, 117 times higher in multiple sclerosis, 173 times higher in Parkinson's, and 360 times higher in Alzheimer's or dementia when compared with headache disorders. And we're mostly talking about migraine, but as that's the most common one, but I think it's really important to know that the world of headache is very deep. There actually exist over 300 different kinds of headache disorders. And these disorders are more than headaches. Headache is a symptom. Headaches, for whatever reason, don't seem to be taken too seriously. I think probably because it's a invisible illness that people can't see. But they can be quite severe. So I'll give you an example. There's a disorder called cluster headache, where the headaches are very seasonal. They come in clusters, and they're often described as one of the most painful conditions that we know of. And cluster headache is unfortunately also very commonly coined as suicide headaches, because it's one of the disorders that has probably the highest amount of suicide associated with it. That's really how bad a headache can get. One of my team members, her husband, she was there as an advocate. She's a caregiver. Her husband suffers from cluster headaches. And he describes it like someone is taking an ice pick and slamming it behind his eye. That's what those headaches feel like. So very disabling, very painful. And it's a bit of an extreme example, but I really think it's important that we get it across that headache disorders are not just your standard dehydration headache, or you have a bit of a headache that kind of goes away if you take some Advil, or just goes away on its own. For people with migraine disorders, headache disorders, drinking more water is not the solution. I mean, it definitely helps. Stay hydrated. So basically, when we were there, we were actually advocating for 3 different pieces of legislation. the Headache Act, the Connect for Health Act, and the STEP Act. So let's start with the big one. Let's start with the Headache Act. So what does the Headache Act actually do? And the Headache Act is very, very interesting because it's the first of the kind to be introduced specific for headache legislation. Some of the other acts that we were advocating for are a little bit more comprehensive. It doesn't only deal with headache, but this is specific legislation that was made for headache and is very, very new. It's just came out in 2025. So what does the Headache Act actually do? So what it does is that it creates a coordinated, time-limited initiative at the Health and Human Services, HHS, with a national plan, annual reporting to Congress, and cross-agency data work, and an expert advisory council. So really, the aim of it is essentially to coordinate and streamline headache care and headache research. Right now, it's not talking about too many action steps such as, we need to put this much funding into this. It's more about forming groups, and these groups are going to dive deeper and give us recommendations on how we should proceed with addressing the headache population that we have. So first, we established the National Headache Disorders Initiative at the HHS, and what that is we're establishing a comprehensive program that addresses the medical, social, and economic impacts of headache disorders and grows the clinical and research workforce. And, it's going to coordinate existing federal efforts that touch headache research, care, education, and pain, and aligns resources with disease burden, because we know right now the amount of spending does not anywhere match the disease burden of headache currently. And the initiative is also going to help prioritize research to speed development of accurate, efficient, effective diagnostics and therapeutics at a low cost. I want to loop back a little bit to migraine and headache research. So in the past 10 years, there has been a new migraine medication that was released. They're called the anti-CGRPs, and they are really revolutionary medications, right? They're taking people with chronic migraine, more than 15 headache days a month, and converting them to episodic. So we're seeing people going from 30 days to as little as 6 to 7 days. And the interesting thing about the anti-CGRPs is that they were actually the first migraine medication that was developed specifically for migraine prevention. So we had some abortive drugs before, but for prevention, a lot of the drugs that they were using to manage migraine in the past, those medications were initially actually created for something else, and then they were used for headache after. So an example is verapamil. Verapamil was originally developed for high blood pressure, Topamax, anti-seizure, right? Amitriptyline originally for depression, but they found these medications to be also helpful for migraine prevention, so they started prescribing it as preventatives. Contrast that with anti-CGRP. This is where they said, okay, our problem is that we have these chronic migraine patients and they need a better preventative solution. And with very focused research, very focused development, we finally came out with the first class of medications that help with migraine prevention. So I want to highlight that because I think that really just goes to show how if there's a coordinated effort and there's a lot of focus and collaboration, there is still a lot of room to grow. There's still a lot of room to grow, and there are a lot of avenues that we can explore for headache and migraine treatment, but we just don't have the funding. We just don't have enough resources being allocated to headache and migraine. And I think if we were able to do that and get better headache care across the country, the benefits would not only would it improve the quality of life for those suffering from headache and vestibular disorders, but the economic boon would be huge as well. Because like I said, these disorders really impact people at their most productive years, and 30s. Many of these people can't work efficiently. So if we could address this, we're looking at a lot of economic output as well. So kind of moving on, what else does the Headache Act do? The Headache Act is also forming an advisory council on headache disorders research, care, and services. And it'll include federal agencies, patient advocates, clinicians, and researchers. And it's also going to form a database for cross-agency real-world data sharing and utilizing artificial intelligence as well. And of course, to keep them accountable, there's going to be a national plan and there's going to be an annual report to Congress. Make sure that we're on track. And so essentially, it's creating a coordinating hub that aligns federal efforts through an advisory council. We're going to share data, common measures. And the most interesting thing is that the Headache Act wasn't pulled out of thin air. It was largely based off the national plan approach for other diseases. For example, National Plan to End Parkinson's, which was bipartisan. And so the Headache Act is really being built off something that we already know works well. So it's definitely a little bit abstract. It's talking about forming these initiatives groups that are going to help us streamline headache research and headache care, because we need these groups to help direct us in terms of how we want to appropriate funding, how we want to conduct the research, and how we're going to coordinate between various healthcare agencies. So let's move on. The other two acts are probably a lot simpler to understand. And so let's start with the Connect for Health Act. And Connect Health for Health Act is essentially just pushing for expanding telehealth services for Medicare. With the government shutdown and some various changes, telehealth for Medicare has been on some, thin ice. And it's actually not permanent. So with COVID, of course, telehealth became really much more common. And then so there were, exceptions made for that time. And then as people got more used to telehealth and realized just how good it can be, now we really need legislation that enacts permanent telehealth benefits for Medicare beneficiaries. And this is really important because for migraine patients, there's only one headache specialist physician per 44,000 patients. And if you are someone who lives in a rural area, your headache specialist is probably going to be in an urban place. So you would have to travel. And traveling with migraine or headache disorders is not a simple task to do. Say for some of our patients, they deal with a lot of motion sensitivity. Getting in a car, driving for a few hours to get to the city to see your headache doctor probably is not the most efficient way to do it. And this is where telehealth can really come in and make sure that our headache patients are getting the care that they need and the care that they deserve. So it would also help to create a lot more stability in the healthcare system. If we know someone is getting the care they need and the headache specialists are more accessible, then that means our patients are better managed and they're less likely to experience emergencies that would require visits to urgent care or the ED, which are both ultimately going to drive up healthcare costs. And then the final act, that we were advocating for, I think this one is something that most headache and migraine patients will resonate with. I think it's really, really important, and it is the Safe Step Act. So asking our lawmakers to co-sponsor the Safe Step Act. And so what is the Safe Step Act? So the Safe Step Act was made to address current fail first policies that we're seeing with a lot of health insurance companies. So remember how I mentioned how revolutionary these anti-CGRP medications are? Because they're pretty new, they are still quite expensive. But the leading neurology healthcare associations are already coming out with guidelines that saying that these medications, anti-CGRPs, really should be first line. They should be first line for our headache patients. But these medications are expensive, and so insurance companies aren't so willing to reimburse for them. And what they insist on is that you have to try a few different more traditional, generic, cheaper medications before they're going to approve and authorize the prescription of these anti-CGRP medications. So naturally, this is very, very frustrating. The physician wants to prescribe one of these medications. The patient wants to be on this medication, but then we have this middleman, the health insurance company, saying, no, you can't jump onto that medication. You have to try some of these other medications first to see if they work. And it's only if they don't work that you can go on to these anti-CGRPs. And this is really, really big problem. Most insurance companies are going to recommend that you try at least 3 different medications before they'll approve the medication that you actually need. And generally speaking, for these medications, we're all looking at 3-month trials to determine whether they work or not. So you're looking at a 9-month wait time till you get your medication. And going beyond that, headache disorders, migraine disorders, there's still a huge lack of awareness among them, especially for some of these more obscure headache disorders. And I would say that across the healthcare spectrum, across lay people, this takes migraine patients an average of 7 years to receive a migraine diagnosis. So imagine it took you 7 years to finally get to this diagnosis. Getting into a headache center is already very, very long. We're looking at 6-month waits, 9-month waits. And then when you finally get in and the physician wants to put you on a medication, but they can't do that because of the insurance company, then you're looking at an additional 9 months till you get the medication that you need. So with these Safe Step Acts, what's happening is people are going through a lot. 93% of migraine patients report having to do these fail first policies with their insurance. Most of them had to try at least 3 medications. 89% of them reported an adverse impact on their quality of life and, of course, also on their work life. And like I said earlier, we know if migraine attacks are not addressed properly early, then the brain can get more sensitive, people can become more sensitive, and our patients, unfortunately, their conditions can progress from episodic to chronic, which is ultimately just going to be more expensive for these insurance companies. And also, when you prevent people from taking the medication that they need, again, they're more likely to go to the emergency room, and that's also a huge cost. These fail first policies, they really don't benefit anybody. And I would say for migraine patients, it's a common problem, and it's a really big problem that a lot of them have. And with the Safe Step Act, we're not even just letting go of the reins. Insurance still has some degree of control of what can or can't be done, how these medication protocols should work. And instead, we're just asking for a group of exceptions. And these exceptions are all very, very reasonable. So the exceptions are the patient has already tried and failed on the required drug. So this is interesting. This has actually happened to me because, I was on one health insurance and then I changed my health insurance and, I still had to fail the medication that I already failed before in the past because I was in a new insurance company, and then I had to re-go through the protocol. So imagine that, luckily I'm someone where my headache presentation is bizarre enough that I actually don't really need the CGRPs. In fact, it's the generic medications that work a little better for me. But imagine that you're someone who needs this medication. It works. It decreases your migraine attacks like 50 to 60% a month. And you've been through the whole gamut to get on the medication. And then maybe you change your job and you have to change your health insurance. And then you have to go through these first policies all over again. It's really absurd. There's no reason that they should have to do that. And also, next exception is that if delayed treatment will cause irreversible consequences. So if we think the drug, or the physician thinks the drug, is going to prevent someone from converting from episodic to chronic, or essentially that if they're having frequent enough attacks that it could very well get worse without the proper medication, then we should have an exemption of the fail first policy. And then of course, the next exemption is if the required fail first drug is going to cause harm to the patient, then we really have no business telling the patient and the physician that this patient should be on this medication. The next exemption is if we think that these fail first policies, the required drug that they need to take, is going to prevent a patient from working or fulfilling activities of daily living, then we would also request an exemption for these patients to get on the medication that they need. And then the final exemption is that if the patient is already stable on their current medication. So if they're already stable on this medication, and then say, for example, they got a new job and they switch insurance companies, the new insurance company shouldn't be able to tell them that, hey, you still have to fail these medications before you can get on the one that you already know is working for you. So that's the Safe Step Act. So kind of went over all three acts there. I know it's a lot of information to digest, but again, I was really, really glad to be there. It was an amazing experience. I feel like I'm still high off the whole thing. It's just being around so many other headache advocates, caregivers, clinicians, all of us so passionate about making a difference. There are over 300 of us this year, and it looks to be growing year over year. And I was just very touched by how much effort and how much work everybody was putting in to bring a better future for all our headache patients. So I think I will end that there today. If you'd like to be a part of this, so definitely check out the Alliance for Headache Disorders Advocacy Group. Call your lawmakers, ask them to co-sponsor the Safe Step Act, ask them to co-sponsor the Connect for Health Act. If you can call your senators, ask them to be the lead sponsor for the Headache Act. And as always, if you'd like to learn more about headaches and stay on top of headache and vestibular disorders, don't forget to give this podcast a follow.